So next up is Dr. Jenny Garkavi, I got it right, who is at McMaster University Health Center. She'll be providing us with an update on the advancement of primary immunodeficiency patient care in Ontario, as well as the issues it faces. For all of us who are patients, this is going to be very interesting. This will be both from a pediatric and adult perspective. So Jenny, would you please join me up here?
One, is that okay? So I just want to say again to Michael, I'm out of words. That was really inspiring.
Jenny, can you just adjust the mic a little bit?
Yeah.
Okay,
Maybe a
that's
little
better?
closer to.
Okay. Thank you again, Michael. That was truly inspiring. And I said I was out of words. I don't know if you could hear me. So thank you again. I'm very happy to be here today. Thank you for inviting me. And I want to congratulate Canada for organizing this day. This is really important and an honor to be here today. I don't have any disclosures. I'm not one of those cool people yet, but maybe someday. And we'll be talking today about a brief overview, what exactly is primary immunodeficiency, treatments, advancement in diagnosis, as well as advocacy, which is very close to my heart topic. Now let's start by names. So back in the 70s and 60s, we used to call that primary immunodeficiency, and the term primary meant it was something that you were born with, congenital, and immunodeficiency meant that you are susceptible to infections. So they had in 1971 this committee from the World Health Organization organized and tried to classify different immunodeficiencies. But then over time, it's been almost 50 years since, over time we understood that immunodeficiency is so much more than just having recurrent infections. And then after doing all that research and work, and we realized that we need to be more inclusive. And in 2017, every few years there's a meeting of the International Union of Immunological Societies, and they decided to rename primary immunodeficiency to inborn errors of immunity to become more inclusive. And I have to admit that I haven't got used to that term, so I still call it primary immunodeficiency. You'll have to bear with me. So let's talk a little bit about rare diseases. And why is it worth advocating for rare diseases? And of course, immunodeficiency would be a rare disease, but if you look at the Canadian population, it's almost 10% of 10% of the Canadian population would have a rare disease. Now, this is quite a lot if you think about it in terms of numbers. And when we think about immunodeficiency, of course, we consider that to be a rare disease. But there's a study that was done in 2015 that showed that immunodeficiency is as frequent as 1 every 2,000 births. Now, and of course, severe combined immunodeficiency is of course rare, and it's between 1 to 2 cases every 100,000 people. But I want to walk you through math exercise for a second. So we have about 15 million people living in Ontario. And if I'm taking that number, it means that there are about 7,000 people living in Ontario with immunodeficiency. And if I'm looking at the entire Canadian population, it's going to be about 20,000 people living with immunodeficiency. Now, I know for myself and for my colleagues that we don't treat so many patients, right? And of course, they're being underdiagnosed. And this is just a slide about rare diseases in general. I want to walk you through the journey of what happens to a patient with immunodeficiency. It can take up to 5 years or more until they're being diagnosed. 70% of them will be misdiagnosed at some point. 20% of the patients have seen at least 8 different healthcare providers. So you can see that it's quite a challenge. And then when I was prepared for this talk, I looked at what would be the consequences. And this is a study they looked at the quality of life of patients with primary immunodeficiency and compared them both to healthy individuals and people who live with other chronic conditions like diabetes or arthritis. And they saw that patients with immunodeficiency have a much lower quality of life compared to any chronic disease that they looked into or compared to healthy individuals. Now, why is it still such a rare disease? And why is it being so underdiagnosed? Now, the first thing that came to my mind is the perceived complexity of clinical immunology. I can share with you, I have a few learners who said that I don't think I'm smart enough to do immunology, or even those who have done immunology in undergrad, they have this kind of difficulty to say, like, I want to become a clinical immunologist because of the perceived complexity that this profession has. There's also lack of awareness. So med students, unless they actively pursue more exposure, they might not see a patient with primary immunodeficiency because a lot of the patients are being followed in clinics, and those are specialized clinics, and they're not part of the curriculum, unfortunately. There's also limited training programs in Canada. So, for example, now I have a brilliant resident who wants to do immunology. He doesn't have anywhere to train, do adult immunology. He has to travel to the States, and I hope they won't steal him, and he'll come back to us. There's also overlap with other subspecialties. So, for example, if someone has arthritis, they will be seen by a rheumatologist. If someone has anemia, sorry, they will be followed by a hematologist. And then sometimes you're just not invited to the party as immunologist. There's also, even within our field, limited patient exposure. So, for example, I've done my training at SickKids, and there are over 600 different diseases, and I know that I haven't seen them all. So even within our field, there's also limited patient exposure, and of course, the compensation, which is, I don't know if you're aware of that, but Ontario OMIP doesn't consider immunodeficiency to be a chronic disease, surprisingly. So let's talk about what exactly is immunodeficiency. So of course, you have to think about infections. It could be bacterial, it could be viral, it could be fungal, or it could be all together. But sometimes it can take many, many years until you kind of meet your nemesis. So for example, EBV virus or CMV virus can cause problems, but otherwise, if you haven't met CMV or EBV, you'll be fine and you'll be able to fight off infections. Another thing that is very, very frequent on a global level is food allergies, environmental allergies, asthma. People don't think about that as a possible immunodeficiency, but it can definitely be part of it. And there's also autoimmunity, like arthritis, kidney problems, stomach issues that can also be part of an immunodeficiency. And finally, lymphoma or any other unusual malignancy that can also present as a complication. And when I think about someone who had lymphoma, was treated for lymphoma, and then had a relapse, I can help myself by saying maybe they have an immune problem. So I know for sure that many subspecialties do not see that as a possible immunodeficiency. So in the past, we used to think about immunodeficiency as a spectrum. You can have a mild disease or you can have a severe disease. But today we know that we have to look at this as a landscape. Patients may have both allergy, both infections, autoinflammation, malignancy, and there's a lot of overlap. And this has kind of reminded me the story about the blind man and the elephant. Like every blind man goes to explore the elephant, and one can see the tail being a rope, and that one thinks it's a wall. And everyone has kind of their own perspective, but you have to look at the big picture. And the immune system is probably the most important organ in the body because it's responsible for all of it. You have to look at the big picture and kind of think about it differently. Now, how would we diagnose immunodeficiency? So we're thinking about history, which traditionally we used to teach that in med schools about the warning signs of immunodeficiency, like having recurrent infections, multiple ear infections, pneumonia, or family history of immunodeficiency. But we know today that it's so much more, as I already showed you. There's also investigations that we can do, we're going to talk about, and genetic testing. Why do we want to do all that work? So why early diagnosis is so important? Of course, we want to intervene very, very early as much as possible. We want to reduce mortality. We want to improve the prognosis that patients have, and we want to improve quality of life. And when we try to convince policymakers, we also want to reduce costs. And this is kind of our vision. We want to see a world in which every patient with inborn errors of immunity benefits from both clinical and scientific knowledge, allowing them to live their lives to their full potential. Now, when it comes to testing in immunology, it's like being a child in a candy store. You kind of want to try everything. So we can talk a little bit about blood work. We try to understand your immune system a little bit better, so we can look at the cell numbers, and we can look at the cell function, and we can do dynamic testing. So, for example, if someone has been vaccinated, I can check for baseline vaccine titer, and then give the vaccine and see if the immune system is able to learn or remember being vaccinated. And this is just one example for a functional assay. We have many fancy blood work that we can do. And there's also an important screening that I wanted to mention. So Ontario was the first province that implemented newborn screen. This was a very proud moment for us as immunologists. I can say that since 2013, there was not even one child that was missed by newborn screen. This is my mentor from SickKids, who is kind of behind it. And this really gives you the opportunity to detect the patient early enough and prevent reversible damage to happen. Now let's talk a little bit about genetic testing. So, of course, with congenital disorders, we want to try to look at the genes that are kind of the recipe on how proteins will be produced in our body. So many of these disorders are genetic in nature, and Canada is extremely diverse from a genetic standpoint. There are over 450 different ethnicities in Canada. And when we talk about possible, thank you. Sorry, I'm having from home. So when we talk about possible outcomes from genetic testing, we also we can think about this as kind of like try to understand the immune system a little bit better. But there's also a lot of value to diagnostic closure. So, for example, I have a 54-year-old patient who had symptoms since she was a child, and her entire life she was told that everything that happened to her was because she has diabetes, and her diabetes was not well controlled. And only at the age of 54, four decades later, after her first presentation, she was finally diagnosed with immunodeficiency. Now, of course, it has value because now I can treat her better. I can choose a certain targeted therapy, so it helps me treat her better. The diagnostic closure has a lot of value. That was a very beautiful moment when we discussed the diagnosis. And there's also much value because now we have prognostic awareness. And I kind of, based on the change that she has in her gene, we can say this is most likely will happen in the future as well. And we also have a huge value of family planning. So for example, I had a patient who was diagnosed when he was 2 years old. And when mom got pregnant again, she had the diagnosis done for the new baby. During the pregnancy, she had amniocentesis. We did the genetic testing on the baby. And we were able to start treatment very, very early before this baby even had any issues. So we started treatment at 4 months of age. And he's doing so much better than his brother because we were able to intervene very, very early. Now, what are possible outcomes? So, of course, possible outcome would be that we find an answer, which is the ideal scenario. And unfortunately, in many cases, we can't find the answer. But there's also the maybe answer. And because most of the progress in immunology happened probably in the past decade, that there's a lot of changes in the genes that we see that we don't know how to assess quite yet. So it's kind of up to us to decide whether this is disease causing or this is just a benign change in the genes. Now, this is a very proud moment for us as immunologists. So I don't know if you can see that I was born somewhere here, and I decided I wanted to be an immunologist somewhere here. And by the time I became an immunologist, there was at least 300 diseases. And this is being updated every few years. And I heard that in 2024, we're going to have more than 600 different conditions. Now let's talk briefly about treatments. You already heard today about bone marrow transplants. So basically what we do, we take the stem cells. This is the father and mother of the immune system. We take the healthy cells and we give them to the patient after being treated with chemotherapy to make more room for the new cells to come and hope to reestablish normal immune function. This is reserved for kind of the extreme cases. Another treatment that we have to offer is IVIG replacement therapy, which is an infusion of antibodies coming from healthy donors that is given every 3 to 4 weeks. There is an option to do the same treatment at home with sub-Q every week. And there's another new option that can be given every month with the same principle, under the skin at home without coming to the hospital. Now, I have to say that as an immunologist, I do like to see my patients quite often. So I like the IV option better, but I also recognize how much you don't like to come to the hospital. So I do offer that to all my patients, but then it comes with a price that you kind of take over on your own care. It can't work for every family. And there's also the compromise that you don't see us that often. Now, I didn't share anything about loss of function when it comes to the immune system versus gain of function. So loss of function would be when something is missing, which leads to a weak immune system. And then that can be replaced, for example, with IVIG replacement therapy. Now, a lot of the disorders are gain function, which means that the immune system is overactive. And this is something that we can target and give a specific biologic treatment for that, or any immunosuppression. And this is a brief look into the future. So gene therapy is, every time I go to a conference, I hear more and more about gene therapy. Gene therapy means that we take cells from the patient, we manipulate them somehow in the lab, and then we return them to the patient. And then you can see here how many new publications and we're almost at 20,000 results when they look at gene therapy and immune deficiency together. So there's definitely a lot of work done behind the scenes to help patients with immune deficiency. Now, what else needs to be done? Something that I see a lot in my practice is the access to care. So anyone who lives in the GTA is quite lucky because you have access to care, but remote areas in Ontario do not have an immunologist. So this is something that I think we need to continue working on. There's also the costs of treatments in adult patients. Once they turn 18, they lose the coverage. There are a lot of, there's a lot of advocacy that we need to do in that sense. There's also the use of off-label medications. So we, as a subspecialty, we have to borrow many medications from other subspecialties. And because immunodeficiency is rare, it's not listed as an indication, we also have to convince the insurance companies to provide with the medication. We have to convince the hospital to pay for it sometimes. So we have a lot of challenges when it comes to that. And there's also the access to advanced therapies that we need to work with Health Canada to approve and bring to Canada. And this is a recent project that I'm very proud to be a part of. A set of recommendations that Immunity Canada worked on for policymakers with medications that needed to be included for immunodeficiency. Now, in terms of what else can we do, we need to continue doing research and bridge the gaps in research and work on future innovations. This is a recent vision that I'm working on, which is for patients who are unable to fight off infections. My vision would be take cells from healthy donors, work in the lab on those cells to be able to fight off infections, and then give it to the patient who is unable to fight off that infection. This is not yet approved by Health Canada, but definitely is available in the US, and there's no reason why it shouldn't be available here as well. And this is kind of a summary of where we're at. So in the 50s or 70s, it used to be only increased infections. And then over time, we learned that immunodeficiency is so much more. We improved in terms of the diagnosis, and we're improving in terms of therapy. And now we're talking more about precision medication, precision medicine, and targeted therapies versus a kind of one suit fits all. And finally, raising awareness, as you are doing today already, involvement in research, policy changes, and I always bring back to any talk I give in immunology. I see the clinical immunologists as physicians who think differently, but I also think that it fits the patients because the patients are also very different from what we're used to see. And this is my final message. Please don't stay alone. Immunodeficiency can be a difficult condition, so getting support and providing support is important, and I'm happy to take questions. Thank you.
We have questions? Questions for Dr. Garkami?
Yeah, I do. You were talking, about the causes, it could be genetic, environmental, viral, we're not sure. Can it be all three of those or any one? Absolutely. So there's really no common cause as to why I got what I got.
I would say a lot of the disorders are genetics. And there's also a lot of the time that we, as immunologists, are unable to find the cause. And of course, other factors will come into play. But I would say the most common one is the genetic disorders.
Okay, and taking that one step further, I was diagnosed like mine. I was probably close to 70 when I discovered I had CVID. And of course, I'm on subcutaneous infusion. Yeah, good. And with the gamma globulin, and I'm doing fine. I have not had the sinus infections, pneumonia, and UTIs, and all that. It's kind of gone away. It's really quite good. But for us who have it, maybe a genetic situation, what would you recommend to my relatives, my kids and grandkids about what they should be looking at
Yeah.
going forward so that,
Yeah, that's an excellent question. I would start with trying to figure out what is the genetic problem in the patient, and then take it from there and test their children, or immediate family members. This is a very frequent scenario when we start with one patient and then other family members are being diagnosed as well. Because even if in a family that has the same genetic defect, patients can look entirely different from one another. So I would start with doing genetic testing. I think, sorry, I think that everyone deserves to get this today, at least in 2024. Start with you and move forward and see if the kids are affected as well.
So one follow-up question before we go to Cindy. How easy is access to genetic testing in Ontario?
So there is a genetic panel that is covered by OHIP. It has about 250 genes on it. I have to say that we kind of outgrown that panel because we have about 600 different diseases. And so what I usually would do, I would start with what's covered by OHIP. And if that comes back negative and I still suspect that there is an immune disorder that hasn't been well characterized, I would send it to the US as an out-of-country candidate. There are also advanced genetic testing that we can do, but that would be more research-based. And some centers would do that as well. But I would start with what's covered by OHIP.
Is it easily accessed in
Yes.
Ontario?
Yes, it's very easy, just, yeah. I don't think it can be easily done from the community, but any hospital should be able to send it.
Patrick?
Maybe just to add to that, I was speaking later on for our daughters, the genetic testing actually was sent to the US. So as a family, we were all tested about almost over a month, but it was sent to the US. So my question was, so thank you for the presentation. Question is, we talked about gene therapy. I've heard a lot about it, in my specific circles. How long do you think before it'll start to be a true treatment option for some of the, I know there's a wide range depending on what you're treating. But it sounds like there's more and more advances happening all the time. Like how long do you estimate it'll be before it'll start showing up as a treatment?
Absolutely, yeah, so the problem with gene therapy is that now every patient who so far received the gene therapy was through a research study. Yeah, I know that, I think Alberta, I know that there's Social Calgary, does some gene therapy for a very specific defect. This is the only gene therapy I'm familiar with that is available for Canadians. I know a few patients who travel to Europe and the US to get treatment. So I think there's a lot of work that is being done. Every time I go to a conference, I hear more and more about gene therapy, like lots of sessions on this. And a lot of work that is being done from a technology standpoint on how to make this more accessible. Unfortunately, because the diseases are rare, the pharma companies are always interested in investing in this. So in the meantime, unfortunately, it's only through research.
Thank you. Cal?
Thank you. I've got two questions. First is who aren't known to have an autoimmune or an inborn error of immunity. But they present with, say, lymphomas or autoimmune conditions. How often do those people automatically get tested for PIDs? Because, you would think that especially, say, lymphomas that might be more common among people with PIDs, that might trigger automatic testing, which would then follow on for earlier treatment, better outcomes. My second question is there a genetic registry in Canada and active research being done to to try to find those commonalities and try to name more genes or combinations of genes for the various IEs?
Yeah, so I can quickly answer the second question. There's not yet a Canadian registry that's been established. We're working on this. There's the Canadian Immunology Network of many doctors who want to do that project, and we're working on creating a registry for all Canadian patients. Some hospitals do have a registry, for sure, but it's not a collaborative project yet. But it's in the works, for sure. We have a meeting at the beginning of November to discuss exactly that. And then you asked about other presentations of immunodeficiency. So it was only last week that I gave a similar talk in my hospital, and I got a few referrals already about patients who had lymphoma and had a relapse of lymphoma. And I do plan to do genetic testing on them and kind of learn more about the immune system and try to figure out why things are happening the way they are. Unfortunately, we need to do more kind of advocacy and advertise ourselves and do more PR for clinical immunology and show that we need to be invited for those cases. But I think that classically, most of the referrals that we still do get would be for recurrent infections, because people just don't recognize how like, in terms of expanding the symptoms and the presentations, how frequent that would be. And I think that if I'm looking at the last decade, I would say that we are improving in that, but we still have so much work to do.
Any other questions about Bernie?
I have a pretty specific question. So I have 5 kids, 3 boys who all have CVID, 2 girls who do not. We did genetic testing, whole exome sequencing, whole genome sequencing, and there are no 1 genes responsible for the immune disorder. So what we were told is that it's a number of genes responsible and possibly environmental factors. So do you know if there's any research being done to look at multiple genes or the impact of environment on immune disorders?
So I would say yes, for sure. I think that there is a researcher in the US who looks into, this is a field that is called epigenetics, meaning that the genes look okay, but something that revolves around them, like other factors, also come into play. So there's a researcher in the US that looks into this. And I can look up your name later if you're interested.
Yes, that would be lovely.
Any other questions here?
Thank you. Can you hear me? Thanks for your talk. Your final message is interesting. It says getting support from the community is important, so as offering support. My nephew over there spoke about his experience. And it seems to me what you do is really, really, really hard. You outline all the challenges and difficulties. And doctors and nurses and specialists in the hospitals, understandably, are focused on the medicine, the science, especially for something this complicated. But it seems to me, from my experience with this thing, what's missing in a hospital is what my nephew touched on. There's more than the science, there's more than the medicine, there's more than the operation. What you do is extremely important, but there's an emotional side, a spiritual side, a mental side. This affects the mind, the soul, the heart, and all those things that makes us people. That's not in hospitals.
I couldn't agree more.
And where I'm going with this, and I think you know, is for most of us who have been in a hospital, we're there for a day or two, maybe a week. But we're talking about patients that are there for weeks, months, years. And that's a whole different other thing. And their friends and family, although they love them, they're not equipped to necessarily provide that support. They're lost at sea. Most of us don't want to be anywhere near a hospital. We're frightened of them. They're not, God bless people who work in hospitals. I could never work in a hospital. I'm not wired that way. And thank God there are people like you that do. But that's missing in our hospital system. And is there any, and, you know, somebody walked into to my nephew and changed his life. People need that kind of support, just as much as they need the mental, the medicine, the operation, the this, the that. And is there any consideration on how that missing link, you know, can be provided? Thank you.
I couldn't agree more. I have to say that every time that I feel there's a need for that, I involve the social worker that we work with. But this is pretty much it. And I think there's a lot of room for more to be done in that sense as well. I think we're all working on a very kind of, in a very busy health system. I did say that, but when people talking about, well, in this year, the system might collapse because we don't have enough of doctors or nurses or et cetera, et cetera, et cetera. And I'm saying, you know what, maybe we don't wanna do that, but maybe the collapse has happened already. And we need to do so much more, for our patients in terms of, getting the mentorship that Michael, for example, did. And this is a service that I don't think that exists in any hospital.
Any other questions for her? I started under organization, I think that's some service that we provide, or we try and provide. That's why we're here. And I hope that, you know, we've been working with Dr. Sharby, and when a patient is diagnosed, the family is referred to organizations like us. We do offer peer support, we do offer financial support as well. We do I am Wendy here today, which is the moderator of our community master program. And we do have family support groups and patient support groups. And we try our best to connect and work with families and patients that we can to offer that support. And it is, I think, something we are trying to build a community here. And I know that I don't talk about myself as a patient very often because I try to keep that stuff. And when I was diagnosed, I reached out because I wanted to find people, and I don't think it was that was one of the first patients I wanted to get it together. And I don't think there was something for us at the time to kind of find other people get that kind of support. So I think this organization is important in order to kind of connect for parents to connect with one another and meet other parents who understand that journey. And I think not just for parents, but also for patients to find their people and to be able to, I think what you're saying too is even when you're a patient, your partner doesn't understand in that way, but they can connect with other partners who also see what's going on and understand. Parents can talk to each other, patients can talk to each other. I think those are all separate journeys and they're all separate experiences. And everybody needs to think of each other in certain ways and understand, but also that financial support is super important as well. And understanding that. So that's something that we try and provide and to create that community all here today. Any other questions in the group? Oh,
Perfect. So I just have one question, and I'm really curious because this is very meaningful to me because I'm in the middle where it's like I've been in the medical system for 18 years, and then now being a trainer, being a coach, having background in different studies of kinesiology and stuff like that, I have a very unique perception. So my question is, what I've been interested in is how much, if any, or if so, because I'm very curious, has there been screening on patients with immune deficiencies and also their lifestyles as well? Because the reason why I ask that is because for my journey, in my experience, something that I really, really talk about is as much as we need treatment and help and support and love and care from medical experts and family and everyone around, something that I found that was interesting is all the little things that also cause our immune systems to react as well. So something like lack of hydration, something like lack of sleep, then being exposed to a lot of electromagnetics, so that's through computers and phones and all these other things. And then you want to talk about inflammation based off stress, so when you're depressed and all these different, and then for me, having kidney failure and my cortisol levels being very high and all of these things creating more problems. I was just very curious if there has been more screening, because I've talked to a couple doctors before about this, on the commonalities between immune deficiency as a genetic disease, but then also the environmental factors, kind of what was asked earlier, and how much that has an influence on the change, if that makes sense. Thank you.
That's a good question. I have to admit that I'm not aware of a lot of research that is done in that area. I know for sure a few studies that were done on the quality of sleep. We know that patients with immune deficiency have more sleep disorders, and it's probably a vicious cycle. When you're tired and you have like low energy, and of course your ability to fight off an infection when you're unwell is, of course, would be less than any other healthy individual who have a good night's sleep. So that would be one area that I know for sure there was a lot of research that was done on. I'm not sure that there was done on anything else, but let's collaborate.
I would, yeah. that's-
Yeah,
That sounds great.
I would actually, I would love that, because that's something that, I believe personally, like from my journey and my experience, something that I was not aware of at all. And that's why it's heavily on, said the emotional mental component, because I believe that, in order for you to first want to succeed and enjoy life and even change, you have to have a reason to. Oh, it's weird. Mike's dying. Hopefully you guys can still hear me. But yeah, so that was just my question, and I would absolutely love that. Because I, of course, through my brand Camo and my organization, I've worked with people who have been in hospitals, outside of hospitals, who I've trained and coached, who, you know, I've done conditioning plans, exercise plans, nutrition plans, all these kinds of things. And also for myself, being an example, like I know, for example, if I choose to not sleep, like I know today, I'm gonna have to have a huge nap because I woke up very early. I drove 5 hours yesterday with my team. I was coaching the day before, and then I'm back to it tomorrow. So I know if I don't do that, I'm gonna get sick. So something that's very interesting that I just wanted to point out to you guys, so that hopefully we can try and think about that side too, because what I believe is really cool is that side also gives a sense of hope. You know what I'm saying? And I found that when it was very genetic based only, I felt like I was doomed to that thing. And if it didn't work, I was screwed. But then when I found through my mentors, through my own studies and through my own work and discipline and efforts to exist, necessarily what I explained earlier, how much it has a correlation, not to neglect either side. Does that make sense? Okay, amazing. But yes, let's connect. Let's figure it out. Okay, thank you.
Thank you, thank you. I think that every hospital should have one United Canada representative.
Oh, we love that. I think we can work on that for sure.
Yes.
Any other questions in the room before we go to the online call?
Hi, I'm Michael's mom. We have been in the system for our life. And it was really difficult to show up as a parent because you could get so scared with the results of the tests. And so it's the child, it's the patient, it's the family. And if we're not solid and a sound mind, it's going to impact your child or your spouse, or it's a whole family thing. And bouncing off like what Michael was talking about, and like we had child life specialists, we had social workers, we had all of those things. It wasn't out of lack of effort. It's just that part is really missing for the child, for the family, and the household. And you have to keep in mind when you're coming in there and you're giving us the results or the prognosis, like we devastated, it's a lot to keep, like to be composed, and it just takes the wind out of your sail. And so when you come in and you share that information with us, and like Michael said, like I think there needs to be more attention to the child, to the adult patient, to the family when you're delivering this kind of prognosis, because you can get hooked on numbers. Like I can look back and go, I wanted to be more present for my children, but I was so scared. You know, did they have neutrophils? Like, You know, is it lymphoma today? What is it tomorrow? What's the prognosis? Like you're scared on your mind. And so people are coming in, they're sharing the stuff and they leave. And you've got all of that to process. And then you can't be there for your child. And so I strongly hope anyone who has any influence to help and be mindful when you share information, what you're telling the family, and to be open to have someone come in who has had experience as a patient and really listen to their experience because it will affect you and it'll affect the quality of life in the future. And you need hope. And if you're just being told on a regular basis, these numbers, these results, you know, it's very defeating. So that is my,
Yeah, thank you. And thank you for sharing that. I have to tell you from my own experience, every time that we do have this kind of documentation. So, I walk about an hour and a half with all patients in between. And I think for about an hour and a half, we go over everything. And I know that even after sitting with me an hour and a half, when I go home, I'm gonna have a lot of overthinking and a lot of questions. And sometimes people don't condition themselves yet. I find that patients do not believe us. So you need to, and then what I would do, I would look another meeting in about 2 weeks from the first meeting and just have the same talk again, assuming that the first conversation didn't happen. And because sometimes you need to hear the same kind of speech again and again until that issue drops. And I think a lot of my colleagues do the same when they have patients who need that. But thinking of everything that you said, we need to have someone, so you mentioned child life and social work, but it's not one person with the community who would support you while you're working, and we don't have that. We have no things.
yeah, and that's not to say that there aren't special, unique physicians, nurses, that really fill up, like, you start to live through their lives for your illnesses for so long. Oh, sorry, what I was gonna say is, I should know, we did have, exceptional care from, you know, people that went out of their way, and connected with us. We knew when nurses were getting married, we knew like the things that were coming up, and we did, there wasn't any joy. I'm just suggesting to be more mindful and to make it part of your care, your person. Thank you. Any other questions or comments from the room? Waiting, are there no questions online?
Nope, no questions online.
You mentioned in your presentation that there's a lack of clinical immunologists in Ontario. Is there anything that patients, families, or in Canada, we can advocate? How can we advocate for more clinical immunologists in Ontario? How can we do that?
I think it all comes down to funding eventually, unfortunately, because, so, for example, now I have someone, initially I have to admit that it's kind of rare to find someone who wants to do clinical immunology, for all the reasons that I've mentioned, but once you do have someone like that, they have trouble finding the funding for their training, they have to travel to the States, and then oftentimes they would stay in the States, because they're also immunologists and they get active offers. So I think a lot of it would stem in the funding eventually, and kind of creating more, and I would say inspire people to come to our field.
So obviously, we don't provide funding for a small emergency charity. Yeah, so I'm assuming it means we can help advocate to the province or to the hospital.
Absolutely.
That's something that we can do. And thank you for taking part in our report, which you mentioned, and anyone who's interested in reading it, it's on our website. Got the everything's really important there. Is there anything else that you can think of that as patient organizations, as patients and families, we can do to help move forward in Ontario in regards to the challenges you talked about?
It all comes down to the policy because there are a lot of things that we can do in terms of holding the open communication, funding for treatments, and I can talk about that like completely separate, like at least an hour. I think that there's a target out from so more work to be done in that sense with the government for sure.
Thank you so much, Dr. Kirkby.
Thank you for having me.